Hi, are you Gina?
Hi, yes.
Hi, I'm Keisha. I'm a level 1 nursing student,
Uh-huh.
and I'm assigned to your patient here in room 620.
Oh, okay.
Would you mind giving me a quick SBAR, please?
Sure. In room 620 here is Mr. Ryder Kine. He was admitted at 15:30 or 3:30. He was a direct admit from his provider's office, Dr. Phillips. Um, Mr. Kind is a 67-year-old white male. He lives here in Clearwater, and he lives with his wife at home, Linda. She may be in and out throughout the day. He is oriented times 3. He's 5'11 and 171 pounds. He's a full code status and he has no known allergies. He is on an 1,800 calorie diabetic diet with 2 grams sodium restriction. His primary diagnosis at this time, he has a stage 2 diabetic ulcer on his right heel. He noticed it 3 weeks ago and he tried to do some saltwater soaking, but it wasn't doing any healing and it was in a lot of pain. He was in a lot of pain, so he has this non-healing wound on his right heel. The wound is 5.5 centimeters by 2.5 centimeters with 3 centimeters deep. There's no tunneling. The wound base is pink. It's extending into the dermis, and he has some serosanguinous drainage. I did set up a consult tomorrow with the wound care nurse, and they will come in for evaluation and treatment. But currently, um, we are cleaning and irrigating the wound with 0.9% saline and covering it with a clean, dry, sterile dressing. So we'll be doing that twice a day until he sees the wound care nurse for the consult. Um, he has a secondary diagnosis of diabetes mellitus, and he's type 1. He's had this for 20 years, but up until a few weeks ago, he's been doing pretty well with his glucose ranges, and they had been for the last 9 months in the 120 range. His previous A1C 3 months ago was 5.2, which is great. Currently, his A1C was 6.5, which is not bad, but he's been having recent blood sugars in the last few weeks around 300, which is pretty high. His last insulin was about 5 hours ago. I just took his blood sugar a couple minutes ago and it was 290. The doctor prescribed regular insulin on a sliding scale, and with any levels over 301, that we need to give him a call. So currently, according to the scale, he's going to get 16 units of regular insulin, which sounds like quite a bit, but his blood sugar is pretty close to the level that the doctor noted. And we will give that subcutaneously. He's been getting the shot. He rotates between his thigh, his upper arm, and his lower stomach around his umbilicus. We want to make sure it's at least 1 to 2 inches away. He also gets 20, excuse me, 20 units of NPH insulin at 0,800 and 2,100. Now at 410 or 1610, the patient's pain level due to his foot was a 6 on a 0 to 10 scale, and we treated him with 4 milligrams IV of morphine. He seems to be doing well. He noted recently when I was in that his pain was just a 1 and that he was feeling much better. And he can receive that morphine through his IV, which is right peripheral saline lock, and he can get that every 4 hours as needed. Now, before we give that to him, we want to assess his vital signs and check for respirations, because one of the things you know is with an opioid, your respirations decrease, and when you do push that into the IV, you want to make sure to do that over a minute's time so it's not too rushed for him. Currently, the patient's pupils are equal, reactive to light. His visual acuity is 20/20, both eyes with his glasses on. His lungs are clear to oscillation and unlabored breathing. He denies any hearing loss, dizziness, headaches, sinus complaints, or cough. The patient denies smoking. He does state he drinks 1 beer per week when he's at bowling on Friday nights. and states that bowling is his only exercise, so he doesn't get up too much. His heart rate and rhythm are in normal range. S1 and S2 are present. He denies chest pain, no shortness of breath, or palpitations. He has active bowel sounds in all four quadrants with no distension noted. He is able to get up and use the restroom by himself, and we've counted 320 milliliters so far since he's been admitted. Normal urine and bowel patterns, and he states that his last BM was this morning before he came in. He does have some bilateral neuropathy, so he does have some tingling in his lower extremities, and he states that those have been worse the last 3 months since his blood sugar levels have increased. Now, the patient is at risk on the Braden scale, so we want to make sure we turn him every 2 hours to prevent any more skin damage, and we want to float his heels, that type of thing. Vital signs every 8 hours and before the PRN morphine, and assessing respirations like I stated. The current vital signs at 16:45, just a few minutes ago when I was in, his temperature is 98.4, his pulse is 76, O2 on room air is 96%, his blood pressure is 128/70. And it's about 5 o'clock now, and that is when we're scheduled to give his insulin. We need to monitor his calcium level. That was low. We still have some pending labs like his UA and a few other things that we're taking a look at. We want to give him some education today on his diet, see what's changed maybe in the last few months that's making this increase for him. Wound care, we want to make sure he has proper wound care, medication storage, proper injections, and so he can assess himself maybe for hypo and hyperglycemia. That's about it. If you have any other questions, I'd be happy to answer them.
Okay, yes, I do have a few questions.
Sure.
Why specifically is this client receiving this medication?
Well, he continues to have an uncontrolled high blood sugar level consistently in the 300s, which can be dangerously high. So we want to try and get that under control with this insulin, and this is what the doctor's prescribed to do.
Okay. And what action does the medication have on the body?
The insulin, this one is short acting. They have different varying insulins, but what it does is it attaches to the sugar once in the system, breaks down that sugar in the blood, and distributes it into muscle and fat. This insulin is short acting, so it will only take 30 to 60 minutes to kick in. The peak is at 1 to 5 hours, and duration is 6 to 10 hours. Excuse me, we will want to make sure that he's ordered his meal for the evening and that we will bring it to him within 20 minutes or so after we give him the injection.
Okay. And does the medication have a therapeutic serum level?
Well, blood sugar in general, we like to make sure that it stays between 70 and 100 to be safe. We like to try and get it down to that level. So that's kind of what we feel would be therapeutic for him to get it down to right now.
Okay. And which vital signs must be monitored?
Well, we always want to monitor the vital signs. It's very important to monitor his respirations, his blood pressure in general, and pulse, because sometimes when he becomes hypo or hyperglycemic, it could raise, he could become tacky, and we want to just make sure we're keeping track of that.
Okay. Which physiological parameters should be monitored when the medication is being administered?
Well, we want to check on him to see how he is doing as far as his orientation. Sometimes when you are hypoglycemic, you're diaphoretic, you want to make sure he's oriented, not confused. He could have unsteady gait, weakness, tremor, difficulty concentrating, dysphagia, which I'm sure you know is excessive hunger, headache, tachy, irritability. There's a lot of different signs.
Okay. Um, what interventions must be taught to the client to ensure the medication is administered safely in the hospital setting?
Well, since his wife is coming in, we don't know, exactly what diets they've been following at home, and we want to make sure that she's not bringing in like sodas and different foods. And we kind of want we want to make sure his stress levels kept down because stress is known to increase your glucose. Also, we want him to be reporting to us if he's having any signs or feeling signs of hyperglycemia, or if he's feeling any of those things, the diaphoretic, confused, anything that's not normal for him.
Okay. Well, what interventions must be taught for taking the medication safely at home?
Well, he has been taking medication at home for quite some time, but we want to make sure he's doing it correctly, and um, we want to make sure that he knows the way to handle the medication, that the insulin can be kept on the shelf, if he has a few vials of it, but once he's opened it, he needs to keep that in the refrigerator to maintain, he wants to maintain uh, the clarity, make sure the clarity's fine, keep it within the expiration date, and we want to assure that he is keeping food nearby, because he needs to eat. Maybe keep a snack with him, and also something that has a little bit of sugar into it, and unless in case he has like a hypoglycemic issue.
Okay. What are the side effects and potential adverse reactions?
Well, in the site where we're giving it, he could, like if we're giving it in the stomach, we need to make sure that it's within an inch or two of the umbilicus, so the um, belly button area. And we want to make sure that he's not just giving it in the same area. He needs to rotate it between the sites of the thigh, the upper arm, and the stomach because he could get hardened fatty deposits. Also, we need to monitor after he has got the injection. He could have a reaction as simple as just red or a little bit of swelling, could be some itchiness, um, but could go as severe as anaphylaxis if he's having a reaction.
Okay. And what will you know, or how will you know the medication is effective?
Well, he's going to eat about 30 minutes after, and then we want to come back an hour later and check his blood sugar and see if it's come down at all.
Okay. Well, that's all my questions for now.
Oh, okay, great. Would you like to come in with me?
Oh, yes.
Okay, sure. Mr. Kine? Hello, I'm Gina. I know I came in earlier to take your blood glucose. Would you mind if my student nurse comes in? Okay, great. She'll be doing this one day herself. How are you feeling?
Good.
I know you had a pain level of 1 earlier. Are you doing okay with that?
Yeah.
Okay, super. Having any hypoglycemic or hyperglycemic signs that you know of? Okay. And we're going to, when I checked your blood sugar earlier, it was 290, which is pretty high, but I know you've been having some even higher than that at home lately. Um, the doctor has advised me that if it's between 241 and 300, that you need 16 units of this regular insulin. So we're going to give you that. And do you have any question about the regular insulin at this time? I've got some education sheets that I'll give you at the end. Um, but if you have any questions at any time, feel free to let me know, okay? Could you state for me your name and your birth date or age?
Ryder Kai 67.
Okay, great. I appreciate that. Um, we want to, let me get in the computer here. Okay. So I check them all and make sure that we have the correct information. At 5 o'clock, it's 5 o'clock now. Have you already ordered your meal for the evening?
Yes.
Okay, and we have that coming down about 5:30, so it'll be And just perfect timing for you. If for some reason it gets delayed, you have the call button and let me know and I'll get you a snack, okay? Okay. Got your insulin. Will your wife be in later?
Yep.
Okay, super. Look forward to meeting her. Okay, let me check your ID. And could you state your name again?
Ryder Klein 67.
Okay. The computer says that is right. And I'm going to take your insulin and check the type of insulin. I'm going to check the clarity of the insulin, make sure it's clear, and the expiration date. We're good on that. It's not till 2017. Okay. And this one hasn't been opened yet, so that's fine. Just to make sure you know, after you do open a vial of medication, you need to keep it in the refrigerator. But as long as it's not opened, you can leave it on the shelf or wherever you keep your medication, okay? Also, some of the things you need, I don't know if you have children in the home, but if you ever have children in the home, you want to make sure you have a sharps container so that when you're finished with your needles, that you put those in the sharps container. Even if you don't have any children at home, but you're throwing in the trash, when you take the trash out, it can be pretty dangerous if that needle is there. So we just want to make sure of that. So I'm going to scan your insulin, and that came up great. We're giving this at 1700, so 5 o'clock. And I don't want to note that I've given it until after I have. How's your foot feeling though? Is it okay? Okay, I hope that that dressing change helped. And we will have a wound care doctor come in tomorrow to take a better look at it. I know you're able to get up and use the restroom, but if you need any assistance, we want to help you and make sure that you're using the hat so we can measure your urine output. Okay. We checked that. Where do you normally give your insulin to yourself at home?
In the stomach.
In the stomach? Do you want that again now, or do you normally rotate between your arm, your stomach, and your thigh? Okay. We just want to make sure you're not giving it in the same area over and over, because you could get some hardened fatty deposits, and that could be painful, but we also want to make sure the insulin's breaking down properly, okay? Okay, clean off the top of that. 16 units. I'm going to inject the air. Pull out 16. Okay, use the one tap method. You want to make sure you do that at home so you don't stick yourself. Okay. And I'm going to bring that down here to your stomach. And is this a good spot, or have you used this spot recently? Okay, it's probably a little cold. Okay, going to put bevel up and then straight down 90 degrees. Okay, how's that? Is that all right? Now, if you have any itchiness or redness in that area, please let me know. Put that in the sharps container, but we want to make sure we don't put the trash in there. So we made sure we checked the right dose, the time, the route, the ID band to make sure it's the right person, and the right medication. You're using the short-acting insulin, so it will start working in about 30 to 60 minutes. That's why we want to make sure you have some food on you. All right, now I've got some education things for you. This is regarding your insulin. It's the regular insulin. It's going to tell you, the hospital provides you with all of this information, how you should use it, what happens if you miss a dose, interactions, that kind of thing. You see that, I know you only drink one beer on Friday nights generally, but you see that it does interact with alcohol, some of the antibiotics, things like that. So you just want to make sure you talk to your doctor about those things, okay? So that gives you some information on the regular insulin. And then I know you've been diabetic for about 20 years, so you're not new to this, but things change all the time. So we've got an information packet on diabetes itself, things that you can do. I know you stopped, that you're not smoking, so that's good, but ways that you can be active, different monitoring and meal planning. So we'll give you that one. And this is the 1800 calorie diet with the 2-gram restriction on sodium. I know it's not an exciting diet, but there's ways that we can give you recipes, things like that. We can talk to your wife and you together if that helps. Does she do most of the cooking? Okay, so we can talk to her as well if she monitors your diet a little bit. It's also good to keep a journal. There's applications for your phone now, but you can always just keep a journal so you know what you've eaten during the day. That way, if you have a high blood sugar, you can go back and look and see maybe that what you've eaten. But also remember to keep something sweet with you in your pocket or somewhere near, and maybe a granola bar or something for a snack if you start having hypoglycemia. Do you know some of those signs? Okay. We want to learn at least 3 signs. 1, you could have a headache. 2, you could be diaphoretic, meaning that you could be sweaty. And 3, you could be shaky, have some agitation. So could you tell me at least 3 things maybe that would be signs?
Sweaty, shaky, and
Okay, great. So those are 3 things that you can monitor. But if you have any questions, like if you feel your level of consciousness or you're confused about something, make sure you contact a doctor, a nurse, and we can assist you. But check your blood sugar first so you can tell us what it is, okay? Great. Is there anything else I can get for you now other than your food?
thank you.
Okay. If you need anything, I've got your call light here for you. The rails of the bed are up. We don't want you to fall out, and I've got your heels floating. But we do need to rotate you every couple hours because we want to make sure you don't get any other sores. As you know, this one can be quite painful, and we want to stop from getting any others, okay? All right, wonderful. Well, if you need anything, feel free to hit the buzzer and I will be right in. And I appreciate you letting me bring the student in. Thank you so much, Mr. Pine, and I will be back with your tray, okay? Thank you. Okay,
Okay, I have a couple more questions for you.
absolutely.
Were there any pertinent pieces of information you reviewed before administering the client the medication?
Well, yes. I wanted to check to make sure, well, first, obviously, a few minutes before I checked the blood glucose level. to make sure how many units to give based on the doctor's prescription. Also, just to check any signs for hypoglycemia, hyperglycemia. His level was pretty high. We want, with the medication though, we want to evaluate it and look at it and do the right, the dose, the time, the route, the identification of the patient, and the proper medication and amount.
Okay. And did this information affect your decision to administer the medication?
Yes, it put it on the sliding scale. The doctor had put that between 241, I believe, and 300, or 241 and, is that right? Let me see. 241 and 300 for 16 units. Now, if it would have gone over 300, we would have called the doctor to check to see for sure what he would like.
Okay. Well, those are all my questions. Thank you
Oh,
so
okay.
much for letting me watch and follow you
Absolutely.
in.
Anytime. Come back again.
All right.
Good luck.
Thanks.
Thank you.